Hello, everybody. Welcome to Musculoskeletal Injuries lecture. Today we're going to be talking about all the emergencies that can happen to our musculoskeletal system and also including dislocations. If you haven't done the reading for this week, no worries, just follow along as we go through these slides. All right, let's dive into a brief discussion about the anatomy and physiology behind our musculoskeletal system. The main function of the system is to provide the form and support and stability and the movement that our body needs every day. It consists of the skeleton, so our bones, muscles, cartilage, tendons, ligaments, joints are all part of this big musculoskeletal system, which basically helps our body support itself, protect itself, and provide movement. Our bones make up our skeleton, and they basically protect our internal organs. They are producers of calcium and those important red and white blood cells that help serve the body. Our muscles are part of the muscular system. When they pull and contract, they're going to help assist those bones in movement. To allow that motion, when those bones meet, this is going to be your joint area, the area which allows that different types of movement. We then have tendons, which are connective tissues that connect muscle to bones. And then within those joints, we have those ligaments that connect bones to bones. The musculoskeletal system is also made up of a connective tissue called cartilage. This is usually stiff and it makes that flexible support. It basically reduces the friction of two bones rubbing against each other. And you can find this usually in your nose, your ears, etc. So in a sense, this is a very, very important system that provides that crucial support, stability, and movement that our body needs. When this is harmed in some sort of emergency, it can rank from very mild cases to very severe cases. And we'll be talking about those different types of injuries in the next couple slides and how we can each treat. All right, so next we're going to be talking about the usable injuries to the musculoskeletal system. I'm sure most of you have experienced some sort of injury like this in your lifetime. They're not going to be life-threatening or anything like that. They may cause a lot of pain and discomfort. However, they are quite easily treatable in the field. So these are going to be your common strains, sprains, even tendonitis, and slight minor fractures. So a strain is going to be that stretch or tear in a muscle or tendon, and a sprain is going to be a stretch or tear in a ligament. Remember, ligaments are that connective tissue that connects bone to bone. So like I said, you may have had one of these in the past, whether from sport, overuse, or just general recreation, or just even simply working in the kitchen. What these are accompanied by for signs and symptoms are going to be that specific or diffuse pain. So they may have pain centrally located in a certain area, or it may be diffuse throughout the entire extremity or area, like you can see in this ankle. It's usually accompanied by some swelling, minor bruising. There may be some slight deformity. However, we want to note that these emergencies are wounds that don't have any protruding bones. There's a lot of pain or tenderness, especially on palpation, or if it's just pain chronically as they're at rest. There may be some sort of altered CSMs in that extremity, especially if it's badly been strained. But the main thing we're looking for here is going to be that range of motion, that change in range of motion, and that change in the amount of pressure that can be applied. Let's talk about the different treatments for these types of usable injuries. There's many different ways to treat these, especially in the backcountry or in a remote setting. I'm sure every one of you has done something different. We'll talk about a few key things that I like to do, and we'll also be posting a few different types of splinting videos, etc., to the webpage. So make sure to watch out for those, I believe, next week. The main thing I want to talk about is assessing this injury, and that's going to be basically assessing whether this injury is going to be usable or unusable, and then that dictates what kind of treatment we'll be using or what type of splint. So as a woofer, it's designed as that 72 hours away from advanced care. So we want to make sure and understand if this injury is going to be usable, if that person is going to be able to assist you in evacuating by maybe walking, limping, etc., or if they can continue on. in your excursion, or if it is going to be an unusable injury and you're going to need to think of evacuation routes and immobilization techniques. So, in order to assess this injury, we want to check two things. We want to check their CSMs, obviously, see how intact they are. We want to check that range of motion and then that usability. So, if it's an ankle or if it's a wrist or if it's an elbow, we want to check that range of motion. You can have that person sit down, stand up, whatever works for you. You can have them either spell out the alphabet. You just want to make sure it's in some sort of normal range of motion. Otherwise, if they have broken their wrist, severely fractured their ankle, something like that, and they can't move it at all, that's a red flag, and that may be deemed an unusable injury. Otherwise, the next step we do is going to be test that usability. So we want to see how much pressure that person can put on that injury site. So especially if it's an ankle or a knee or something like that, you can assist them standing up and see if they can apply a slight bit of pressure on that, if they're able to walk out with you. Um, if they can, especially if it's an arm or anything like that, if you can put some slight pressure on it, anything like that, but the arms in general are quite easy because you can easily splint that to the body. However, if we're thinking about some sort of evacuation route, using this test of range of motion and usability, especially on the legs, is going to be a key factor in how you're going to evacuate this patient, especially if it is a bit more of a serious injury. So obviously using a patient in the treatment and evacuation is super helpful. So if you can put some pressure on that injury site and see how much range of motion they have, because maybe they can walk out with you, especially if you just do a slight splint. That's what we're mainly looking for. So for these usable injuries, basically, it's a little strain, a sprain, sprained ankle. We're going to use that RICE therapy that we talked about in the wound injuries lecture. So we're talking about resting, we're talking about icing, we're talking about compressing that injury site and then elevating that. So if you are in a wilderness setting or you have time, utilize all these four techniques as best as you can to help promote that healing faster to that site. We can also assist in some pain medication if that helps. We'll be showing you different techniques for supporting this injury with tape or other types of splinting techniques. Basically compression, you can compress a knee, you can tape an ankle, etc. However, it can get quite tricky, especially you are in a remote setting or somewhere where advanced care is not easily accessible. You're going to have to utilize the resources that you have in your vicinity or even in your backpack or your scooter. So I just want you to always be thinking ahead of what you can supply your first aid kit with. I carry a lot of ACE bandages, so those elastic bandages. Those are really good for just quickly sprinting an ankle or compressing a knee. Some athletic tape is really good. You can also get that athletic pre-wrap tape to put under that ankle. I'll be posting a few different videos of my favorite ways to tape an ankle, wrist, and to splint an arm. So also utilizing a lot of those triangle bandages. Those are super key in a first aid kit. This is just always the things we want to think ahead as woofers. All right, so next we're going to be talking about those unusable injuries, and these are going to be those big, bad, usually open fractures or those major fractures to our extremities, or anything basically deemed unusable by that range of motion test and that usability test. All right, so let's talk about the different treatment guidelines for unusable injuries. We'll go into open fractures and closed fractures as well. So we've learned to and understand how to assess that injury to understand if that range of motion or that usability of that injury has been compromised. And that's going to deem the different types of treatment we'll be using. And we're going to talk about splinting right now and immobilization. So if it is an unusable injury, if they have a suspected femur fracture or if they have a radial open fracture to their arm, anything like that, we're going to want to think about immobilizing and splinting this patient. However, the one thing we want to do before we splint or immobilize anybody is we want to assess those CSMs, so the circulation sensation of movement in that extremity to where that injury has occurred. So let's just talk about and prefaces as someone has fractured their femur, a closed femur fracture or suspected. So we're going to assess their CSMs. This is going to be done right in that treatment monitoring stage. If this is not a life-threatening injury, but it is something we can leave not left untreated. So we need to assess the CSM. So before we even touch or splinted or move the leg, I want to make sure that those are going to be the same before and after I have manipulated that leg. I want to make sure that I haven't done anything negative to cause this person more harm. So after assessing those CSMs, we're going to try to splint this extremity, or we're going to talk about the leg, in a functional anatomical position. So you want to return it gently, that leg, especially if it's bent out of proportion, to an anatomical normal position. So say they're laying on their back, maybe their leg is cast out to the side. Try to arrange it back into a neutral inline position. You'll be watching me do this on a video as well. However, I do want to note that if you meet any sort of resistance, you stop. Or if you meet any excruciating pain from the patient, you stop as well. If that is as far, if you don't get the leg completely in line position, that is as far as you go, and you're going to be splinting it in that position that's comfortable for the patient. When we think about splinting, we think about these two basic guidelines. So if the injury has been deemed to the bone, we want to immobilize the joint above and below. So say we broke our arm, our lower arm bone, we want to immobilize the elbow joint and then the wrist joint to keep that splint immobilized. However, if we've broken our ankle, we want to, that joint ankle, we want to immobilize the bones above and below. So we're going to immobilize the lower leg bone and then the foot as well. We're going to be posting a few different types and techniques of splinting and how to use limited resources in the next week or so you can get an idea of what we expect from you guys when it comes to splinting. There are many different ways to splint a person or a patient. It all works well for whatever you choose to do, especially with the resources you have. I just want to note that it comes down to these two simple guidelines. So if it's the bone, you immobilize the joint above and below, and if it's a joint, you immobilize the bone above and below. If we're with this patient for an extended period of time as well, especially if we're farther away from more advanced care, we can utilize that RICE method, use that active cooling, we can use that compression. You want to really rest this patient, especially if they have suffered some sort of severe injury to an extremity. You can elevate that injury as well. We can utilize some sort of pain medications, but ultimately this patient is going to need evacuation. This patient is going to need to see some advanced care. Lastly, I want to talk about open fractures and how we treat those. So let's go back to that femur fracture, and let's say it's now become an open fracture. So there has been a severe soft tissue wound that has exposed those two bone ends to the open environment. And we talked about this in our open tissue wounds lecture, but I just want to reiterate it again. So the main thing we want to do is irrigate, irrigate, irrigate. Bone infection is a severe, severe risk for any open fracture site. So we want to thoroughly clean this wound with pressure irrigation. So about a liter of clean, sterile water. You really want to clean off those bone ends or exposed bones as best as possible. Just because when we return this patient back into a neutral inline anatomical position, those bone ends could actually slip back into the skin and carry whatever it has in it with it, whether that's dirt, debris, etc., which can cause that severe infection risk. So, but before we move the patient, manipulate them in any way, we want to thoroughly irrigate and clean this wound. We want to protect that bone from freezing or drying out, so we want to pack it with that moist dressings, that clean, sterile bandages to dry. Okay, so on that open femur fracture, I've irrigated the heck out of that wound. I made sure that there's no dirt and debris. I have now anatomically put this patient back in a neutral position. Maybe those bone ends have slipped, maybe they haven't, back into the body. I'm gonna then take and wet a bunch of my moist, clean, sterile gauze or bandages, whatever I have in my first aid kit, and place them over the exposed injury site. And then we're going to put a nice, clean, sterile bandage on top of that as well, and then tape that down or splint that down as best as possible to that site. The main thing I want to note here, though, and then when it comes to splinting, is we want to always keep an area of that. So wherever that open fracture site has happened, we want to make sure we can access that um, while we put that splint on. So I'm going to leave, when I'm splinting this whole leg, especially with the femur fracture, I'm going to leave a little area in my splint where I can go back and access that wound site, because especially if I'm with this patient for an extended period of time, maybe up to 72 hours, I want to have access to that site so I can clean and irrigate and monitor it for infection without having to remove the entire splint and undoing what I have just done. All right, lastly, we're going to be talking about dislocations. And dislocations are basically a displacement of a bone from its normal alignment. These are another musculoskeletal injury. Some signs and symptoms of these are going to be some obvious deformity at that joint site or where this injury has occurred. There may be point tenderness. So when we do that full head to toe, this is why we palpate along the entirety of that collarbone, along that shoulder, on every part of the body, so we can see if there's any pain or tenderness, obviously, but anything out of the normal that we feel anatomically. There's also going to be as if you're limiting or change in the range of motion in this joint. And finally, the treatment for dislocation. So, like it says, this is going to be a complete wilderness protocol. So, as woofers, it is in our protocol that we are able to treat dislocations by reducing them or helping to reduce them. As an EMT in an urban setting, anything like that, it is not in the protocol for an urban setting because they have access to that advanced care. As a woofer, we have this criteria that we may be 72 hours away from care. So they give us these types of treatments to hopefully reduce the need for seeking that advanced care. Some patients that suffer habitual dislocations or that it happens a lot to them may have their own techniques of how to reduce maybe their dislocated shoulder or their digits or their knee that works really well for them. So establishing that history and talking to your patient and understanding what works best for them and how you can assist is the best way possible for treatment. However, if this is a first time dislocation or anything like that, we're going to run over a few different ways to reduce shoulder dislocations, digit dislocations, knee dislocations, and jaw dislocations. I'm going to be posting a few different videos on the classroom, so watch out for those to instruct you how specifically to do that so you can see it visually. However, I'm just going to briefly talk about the basic guidelines for reducing dislocations. So we want to assess this injury. We're going to see those signs and symptoms. We're going to understand that there may be some sort of deformity. Let's talk about shoulder dislocations for an example. So, like we do with the treatment for any unusable injury or usable injury, we want to check those CSMs because we're going to start manipulating this shoulder or this arm or this knee. And we want to make sure those CSMs, so say in my fingers, are going to be the same as they are after that I've reduced this dislocation. We can then provide that slow traction in line, and I'll give you those different types of techniques of how to do it. There's 3 different ways to reduce a shoulder dislocation. But the one thing I want to note is we're going to absolutely stop, like we do with unusable injuries, is if we're met with any sort of resistance or pain from that patient. If that occurs, or if no reduction occurs, we're going to splint that patient in a position of comfort. So if that shoulder, if you've tried your reduction techniques, it doesn't work, we're going to splint that, sling and swath that patient, whatever is comfortable for them. We then have to note that if the CSMs have changed after we've done that dislocation, we want to try to place that extremity or whatever it is back into that anatomical position and then get them to a more advanced care. That means something in that reduction stage went wrong, causing some sort of altered CSMs to happen. We can use the rice and pain medications after reduction has occurred. So if you've reduced that shoulder back to an anatomical position, we can put some ice on it. We can apply a nice little splint and some sort of like paracetamol, anything like that that can help this patient with that pain. And then we'll talk about evacuation guidelines as well. So basically, any patient with a first time dislocation, the first time they have dislocated their shoulder or their knee, etc., or one that cannot be reduced, needs to be evacuated. However, if someone has routinely dislocated their shoulder or their knee, and we have successfully reduced that, those people can stay in the field. Well, I forgot there was one last slide. I think I just covered this on the previous one. Thank you for listening to this lecture. If you have any questions, don't hesitate to reach out and ask me. And also, your book does a really good job describing these types of injuries and how we can treat them. And we're going to be posting a lot of visual videos of me reenacting different splinting techniques as well as Erica.